Clinical practice has long relied on specific diagnostic heuristics to identify acute cholecystitis. However, current data suggests these foundational signs are frequently misleading. Medical training emphasizes the classic triad: gallstones, generalized gallbladder wall thickening, and a positive sonographic Murphy sign, a test eliciting pain by pressing the ultrasound probe directly over the gallbladder. The sonographic Murphy sign yields frequent false negatives. A patient's pain response can be masked by analgesic medications or blunted by conditions like diabetic neuropathy. In advanced cases, gangrenous cholecystitis can completely denervate the gallbladder tissue, eliminating the pain response entirely, even as the condition worsens. Generalized wall thickening is similarly problematic. While common in biliary inflammation, it lacks the specificity needed for a standalone diagnosis. This ultrasound shows wall thickening, which isn't exclusively biliary. It routinely occurs in heart failure, hepatitis, or hypoalbuminemia. To be useful, correlate with secondary markers. This CT confirms acute cholecystitis via pericholecystic stranding, inflammatory fat edema, and reactive hepatic hyperemia, indicating increased liver blood flow. Because wall thickening can result from various systemic states, we must look for markers that track actual intraluminal pressure and specific arterial supply. Acute cholecystitis begins with mechanical obstruction, typically a gallstone lodged in the cystic duct. This creates a closed system where internal fluid pressure steadily builds. This pressure dynamic follows Laplace's law. Laplace's law is a physics principle stating that the wall tension of a cylinder or sphere increases proportionally with its internal pressure and radius. As intraluminal pressure spikes, it generates massive outward tension on the gallbladder walls. This tension eventually overpowers the downward resistance of the anterior abdominal wall, creating a distinct outward deformation known as the tensile fundus sign. In this ultrasound, you can see the dilated gallbladder physically pushing the straight line of the anterior abdominal wall outward. This bulge is an objective physical event. An axial CT slice of the same patient confirms the exact same mass effect deforming the abdominal wall boundary. Evaluating this physical deformation provides a more reliable indicator of pathological obstruction than simply measuring the absolute width or length of the organ. While the tensile fundus sign is highly specific, you have to account for the patient's local anatomy to avoid a false negative. Take a look at this CT scan, showing a gallbladder massively distended to 11 by 6 centimeters. Despite the high internal pressure, there is no outward deformation because the gallbladder fundus is positioned immediately deep to a rigid rib bone. When osteology blocks physical expansion, you must rely on secondary inflammatory markers, like pericholecystic stranding near the gallbladder neck. The absence of a tensile fundus sign does not rule out cholecystitis if the local bone structure is physically preventing the deformation. The next step moves away from subjective visual assessments of blood flow to quantifying actual hemodynamics. Trace the vascular anatomy. The common hepatic artery branches into the right hepatic artery, which then gives rise to the cystic artery, the exclusive arterial blood supply to the gallbladder. Clinicians often measure the main hepatic artery velocity. This spectral Doppler readout, which measures the speed and direction of blood flow, shows a velocity of 202.1 centimeters per second. However, relying on the hepatic artery can be misleading. Because it supplies the entire liver, its velocity easily spikes due to unrelated liver pathologies like cirrhosis, metastases, or acute alcoholic hepatitis. A more direct metric is the velocity of the cystic artery. Because it solely perfuses the gallbladder, changes in gallbladder perfusion are reflected here without interference from the rest of the liver. The clinical threshold for the cystic artery is a peak systolic velocity of 40 centimeters per second or higher. A measurement of 48.9, as seen in panel C, yields a 92% positive predictive value. Positive predictive value is the probability that subjects with a positive screening test actually have the disease. Hepatic artery measurements still have value when tracked concurrently. As shown in panel B, values significantly above 100 centimeters per second correlate with right upper quadrant inflammation, providing a useful secondary confirmation. Utilizing these precise cystic artery velocity thresholds removes human subjectivity from the assessment of gallbladder wall hyperemia. If the obstruction persists, mounting intraluminal pressure eventually compresses the gallbladder's own microvasculature. This cuts off blood flow and initiates tissue ischemia. Identifying the progression to gangrene requires monitoring how the organ's appearance changes over a 12 to 24-hour period. These 4 panels track a 2-day progression. What begins as a thin-walled gallbladder devolves into a striated, thickened wall, displaying a cystic artery velocity of 58 centimeters per second and echogenic fat. Echogenic fat reflects ultrasound waves more brightly due to inflammation. During this window, evaluate mucosal integrity. The left ultrasound shows focal loss of the bright mucosal line, indicating localized ischemia. The right CT scan validates this breakdown, showing the exact same area as a dark, hypoenhancing void. Tracking these temporal changes and identifying mucosal discontinuities is how clinicians can diagnose gangrenous progression before the wall completely fails. The endpoint of untreated ischemia is frank wall perforation. Once the tissue tears, intraluminal bile extrudes into the abdomen, triggering peritonitis and sepsis. This ultrasound clearly captures a blowout. You can see the distinct focal defect in the wall, with complex intraluminal fluid extruding directly into the surrounding space. Pay special attention to the bare area of the gallbladder, shown in this 2-panel series. The bare area lacks a peritoneal lining, meaning it is not an intraperitoneal space where free fluid should settle. Fluid localized strictly here strongly suggests a full perforation. There is a specific clinical scenario where the gallbladder's appearance becomes highly deceptive: post-perforation decompression. As bile leaks through the rupture, the gallbladder deflates. Look at this ultrasound of a perforated organ. The extrusion of contents decompresses the lumen, instantly erasing the high wall tension required for a tensile fundus sign and eliminating the distension that triggers the Murphy sign. In a critically ill patient, a negative Murphy sign does not guarantee a healthy gallbladder. It can indicate a dangerous perforation that has already decompressed the organ. To implement this objectively, start with the baseline rule-out criteria. If the gallbladder width measures less than or equal to 2.2 centimeters and appears otherwise normal, acute cholecystitis can be ruled out with high confidence. For cases beyond that baseline, we must move past subjective heuristics. The sonographic Murphy sign and generalized wall thickening are too easily confounded to serve as primary markers. Instead, populate your differential with rigorous, physics-based criteria: the tensile fundus deformation, a cystic artery velocity above 40 centimeters per second, and mucosal layer integrity. And remember, the complete absence of pain or physical distension in a highly symptomatic patient should trigger an immediate search for perforation markers. Integrating quantifiable hemodynamics and biomechanics into your ultrasound protocol provides the objective evidence needed to improve diagnostic confidence and improve patient care.